All righty, so we're going to go ahead and get started. Good morning, everybody. Welcome to Medical Grand Rounds for the long weekend. I'm sure you're all looking forward to it. Before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. This is a statement on the speaker today because I actually see the room half filled today, which is kind of nice to see people in person. So I'm delighted to introduce somebody who needs very little introduction, Dr. Justin Ezekowitz, who's professor of medicine in the Department of Medicine Division of Cardiology and co-director of the Canadian Vigor Center at the University of Alberta. He's a cardiologist at the University Hospital in Mazankowski. His research and clinical focus is heart failure. He's involved in numerous multi-center international clinical trials in heart failure. He's also involved in the design, leadership, and implementation of several investigator-initiated trials funded through governmental and non-governmental research agencies. And he works with population health, registry data, and other data sources on clinical applicable research using advanced data analytics around health system change and disease risk. As Director of Cardiovascular Research at the University of Alberta, he established the CVRI, and he's also president of the Canadian Heart Failure Society between 22 and 25. He has published hundreds and hundreds of manuscripts and continues to do amazing work. And so we're delighted he agreed to present today. His topic is From Failure to Function, Heart Failure 2025 and Beyond. Thanks, Justice.
Well, good morning, and thank you, everybody, for providing coffee. Most importantly, that's all that counts. And thank you, Norman and Jen, for inviting me to speak. And nobody should ever have to put up with that. So first of all, here's my disclosures of interest and relations with anybody. I think this is quite important to show because we work with industry, academic partners, you name it. If they do something about heart failure, we will work with them. And so this whole little, it looks like a stock car racing stickers. They're each individually important in the stuff we do, but one of the things to remember is that the entire ecosystem of clinical trials and heart failures is complex and has a lot of players to work with, which is great, but obviously more work to be done, as you will see. So last week, Dr. Ringrose asked me, would you mind doing medical grand rounds next week? And this is what immediately popped through my mind was, I've got to summarize, there's book chapters with like 700 pages. There's guidelines that read equally long. And there's a lot of data and information out there. So I first panicked. I delayed my response to her because I was like, can I actually do something? And she said, you can recycle some stuff. So there is a little bit of recycling here, in here. And I even came up with some learning objectives. Not that they ever matter, but here they are. So we have some, and you can read faster than I can speak. The first key thing is we now have what's called a universal definition of heart failure. So if you went to medical school in the 60s through 2024s, you may have learned about other ways to describe heart failure and things like congestive heart failure, diastolic heart failure, and you can really you can actually delete those from your brain. The universal definition of heart failure was agreed upon by all the major societies that study heart failure from a research or clinical applicability, and it's up there. You can read it pretty fast. It's a complex clinical syndrome. That's the first thing, is not one disease entity in itself, such as ischemic heart disease or dilated cardiomyopathy, or these terms you may throw around. But heart failure is a broad term we use to encompass all of that. You can kind of see how the other parts that are of that definition will kind of work out. You can imagine that kind of come up with a very nice working definition that clinicians could also apply, as could researchers. So please, from your lexicon, from here on, like I'll mark the day today, delete the word congestive, no longer relevant. You can talk about congestion in the lungs. You can talk about congestion all day long, but that's not the disease state. Diastolic heart failure, I'll come back to in a bit as to why we've deleted that term as well. And a bit of heart failure. It's like having a bit of like metastatic cancer, just a bit, just a touch. Our big terms are heart failure with reduced ejection, HFrEF and HFpEF, and I'll come back to a little bit why we include those definitions still. But there's also this middle term, mid-range, there's been a whole bunch of terms I'll come back to how our CCS guidelines have updated that. This was published online in 2022. The Canadian Heart Failure Society was one of the parts of that universal definition. Placed in context, and this does not lead a lot of information for the average GIM physician in the room or for cardiologists, is heart failure is a high-risk disease. It doesn't matter how many times you're on a CTU, cardiology ward, practicing in the community. Heart failure patients, patients with heart failure, they have a lot of high risk of death. And it's very similar to COPD. There's about a 5 to 10% chance of dying in hospital during that hospitalization, and in between a 10 and 30% chance of dying out of hospital after the next year. So if you think about this, like on the left-hand side, you see atherosclerotic cardiovascular disease, ASCVD. That's the risk. It's very actually, we think it's high profile, but low risk overall. Now, there are exceptions to every rule, but in general, people presenting with a STEMI or non-STEMI acute coronary syndromes are generally low risk. The majority of them are not going to die this next year compared to patients with heart failure. So just putting that in context is actually quite important, just to think, why are we bothering? Now, guidelines, we love guidelines, we hate guidelines, we throw them at walls, we just don't want to look at them. Whatever way you feel about guidelines, they still have a vital role in how we function. So this is a good picture from just, from hiking, showing that even in the clouds when there's fire out and kind of burning smoke, there's a spectrum of how you can feel. You can feel very orange on the left or more white on the right, and it just kind of matters on how you feel. The other part is I'm not going to talk at all really about the pathophysiology today. So that may infuriate some. That's fine. You throw tomatoes if you want. But that is a whole branch of each area that you can think about a molecular signal or mechanism or a protein. That's quite important, and that's the fundamentals of a lot of our clinical implementation of whatever drug we use or diagnostic we use. However, what I'll be talking about is really a bit more about the higher level in terms of when we get to clinical practice. But there are no substitutes. Anytime you do anytime you do any small experiment, that's not a good substitute for a good old-fashioned RCT. And this is Dr. Rob Califf, who is the FDA commissioner, but a long-standing proponent of doing RCTs in pretty much everything. I randomized my coffee this morning, but I'd like to do that every day. But it's important that we randomize everything, because sometimes you think things work, but they really don't. And here's some good examples, just in case you wanted to know about leeches. You got up on a Friday morning, thought, how much can I learn about leeches? So leeches have a place in medicine, but in fact, they're used in some parts of the world for treating heart failure, and they have been used extensively for treating heart failure, because what do? They take some fluid off, they take a bit of blood. So they're kind of like old school bloodletting you see in the bottom right-hand corner. They really don't have a role in heart failure in case you try to write a prescription for that, an inpatient order, leeches to body, probably not going to be filled. But there are actually 10 million medical leeches used every year. This is an older study showing how many times they're used. Rotating tourniquets were actually used. It's hard to believe that they were, but actually you can understand why they were used. But in fact, somebody then came along in 1974, published a randomized clinical trial saying this has no benefit. So people stopped using them. So very important that we kind of move along from the stuff that you don't need to do. Sorry, digoxin's in the middle, and we can talk about digoxin all day long, probably has no role. So our guidelines started, they've had a long history of CCS guidelines, but I'm going to fast forward to 2017. And this is the reason I've got these guidelines up, is because this is the first time we kind of went from a staccato, do one drug, then add another drug, then add another drug in a very kind of linear fashion. We changed it around and said, what does the practicing community need to know, and how will they function? We said, why don't we put this around and go and steal something from both GI and IV and say triple therapy, because who doesn't love the term triple therapy? It seems to roll off the tongue. And so we said, start it up front. Don't wait around for more badness to happen. So MRA, beta blocker, ACE or ARB, just start it up front, and then you can reassess as you go. So don't wait around for do an ACE, start an ACE inhibitor, and then do an EF. Add the beta blocker, then add an echo. It just doesn't quite work. So that was the first year we did, and we were the first kind of guideline to really instrumentally change that paradigm. And then you go down to adding the other things. Fast forward to 2021, now it's quadruple therapy out of the gates. So if somebody has HFrEF, it's quadruple therapy right when you start, and you can see ACE, ARNI, it's an ARNI first strategy, as we feel that data is pretty compelling. ACE, ARB, beta blockers, MRA, and SGLT2s. So that's pretty straightforward. And then you can add the extra things if you feel that's warranted. This is 2021, so you may feel that's somewhat outdated, but at least in between there, I'll show you some trials that have been published that may influence the next round. So what have we done in the 2025? And this will cause some consternation amongst many practitioners as well as academics, scientists, researchers. It doesn't matter what brand, you're going to have some challenges with this. So the CCS, we convened our guidelines panel. I did not chair this one, just for the record, so I don't want people to think that I kind of conjured this up. The terms of mid-range we found were not being well received by the community. So the term non-reduced EF was chosen. Now, it's a vote. Just keep that in mind, like all votes, you can end up with what the general group wants. So as like all committees, so non-reduced. I will say I will struggle with that one, but that is just who I am. So HEF is still there, but we kind of merge them into non-reduced, and you can still have HEF-REF. So keep that in mind that I didn't create the term. And this was presented back in May at our heart failure conference, which I encourage you to do if you want to learn about heart failure in May every year. It's either Toronto or Montreal. It's a really good conference, and happy to share more information. But this is our updated guideline. It was actually supposed to be published earlier this week, which I thought would be perfect timing for this presentation. It got delayed by the publisher, so I'm showing it anyways. And so here's what for the non-reduced EF, you start with an MRA and SGLT2 right out of the gates, and I'll show you some evidence on that. Then you think about other patient considerations. And the thing there you are looking at is on the left-hand side, you can see if they have an elevated BMI and an EF over 45%, you start with an evidence-based GLP-1, and that has a specific term to it, evidence-based, because otherwise you might be using non-evidence-based GLP-1s, which have not been studied in heart failure, and that might actually not be an optimal thing. And on the right-hand side, if they have a good blood pressure, you consider an ARNI, and now recognizing ARNIs are not covered by things like ABC or even private coverage based on the Paragon trial. We didn't get a lot of coverage in Canada, has some coverage in the US, but we did feel it's reasonable to put there based on the evidence that's being accrued. So there's strong recommendations at the top, weaker recommendations down below. Now, how is this made up of in terms of how do we come to this kind of these terms? You can see each one of the drugs in the kind of rows, and you can see what we were looking at. Heart failure hospitalizations, a big driver for all these trials as to how they kind of became positive. And you can see that all of those check the box. They actually reduce heart failure hospitalizations, so that's good. KCCQ is not reduced by many of the drugs, but is, as you can see, by SGLT2s and GLP-1s, but not for the others. So it doesn't change quality of life in the large trials. And 6-minute walk distance, which was used extensively in GLP-1 trials, does show that it does improve 6-minute walk distance, but none of these reduce death. So that's actually very important that we actually very clear in the guidelines. If you're trying to reduce all-cause or cardiovascular mortality, none of these drugs are proven individually or collectively to reduce the risk of dying. I mean, that's probably a bad thing, but at least you're reducing something like heart failure hospitalizations, which lead to subsequent deaths. But overall, in the shorter term trials, they're a year or 2 years, they don't reduce mortality. So what kind of formed the backbone of, say, the MRA recommendation? So we had TopCat Americas, which is a subset of the TopCat trial, which kind of we feel has a high validity. So that was a TopCat, and then you fast forward to Fine Arts, which was published just about last year, and it showed a reduction in cardiovascular death, heart failure hospitalization. You can see these 6,000 patients, an EF over 40%. All with basically, I say, preserved eGFR. So they had to have a GFR that was at least reasonable. Most patients enrolled as an outpatient, 80% as an outpatient. So not started in hospital for the majority of patients. It was versus placebo. So that was a lot of debate whether or not you should have an active control like spironolactone. But of course, there's a rationale to not also do that. But you can kind of see with the totality of things. In the bottom left, you see no change in cardiovascular death, but a strong signal for heart failure hospitalizations and other things. Encourage you to read up on that paper. MRAs we're very comfortable using in the kind of community. So this is just a list of the 3 kind of ones available in practice in Canada. Now, if you want to know about the spironolactone shortage, so we've been working with Health Canada on this whole shortage, and it'll persist over the next couple of months for sure. It's not a single manufacturer. It's actually a lot to do with the complexity of the drug supply and also the generic manufacturers. So Teva, you name the other ones, they all have their own supply chain issues with spironolactone. So you can kind of go there if you're really interested. What about the GLP-1s? So there are really 3 trials, and 2 are with semaglutide, 1 with tirzepatide. And you can see on the left, you've got STEP-HFpEF, and then STEP-HFpEF diabetes, and then the SUMMIT trial. And they all are kind of the same kind of size, 600 to 700 patients. They're all BMIs are elevated, and EFs about 40 or 45%, and included other characteristics often did people have structural abnormalities such as LVH or left atrial volume enlargement, elevated BNPs, or prior hospitalization. They kind of wanted to make sure they had a HEF phenotype. But they're all placebo-controlled RCTs, high quality, usually about a year or two in duration. And I'll talk about just a little bit about each one. Now, I don't think it's kind of relevant to talk about semaglutide reducing weight. So that was actually kind of one of the primary endpoints, was the weight and CRP 6-minute walk distance. Kind of irrelevant in the grand scheme of things in the world of heart failure, but that's how you power a clinical trial. You get the trial done. But in the supplement of this paper, you can kind of find this nice little like heart failure hospitalization reduction. So NT-proBNP went down very quickly on these drugs, and also so did the risk for hospitalization. I don't think we'll see a hazard ratio of 0.31 again in a trial of this nature, but small number of events, but a big signal in terms of the difference between the two drugs, placebo-controlled. So that's actually very indicative. And then when you put it back together on the right-hand side with all the other trials that included patients with heart failure, only selecting out those with heart failure, you can kind of see it's a very consistent signal. So then you go on to tirzepatide, the Summit trial. Now they were doing the same trial, except then they saw the STEP-HF trial results, and they said, change to a primary outcome that's a clinically derived, not CRP, 6-minute walk distance, et cetera, but in fact, change it to a clinical outcome, a clinical composite. And in fact, by and large, it was positive. And you can see that also the KCCQ being positive. So they changed midstream, did a 2-year trial, and over 700 patients or so, a reduction in cardiovascular events. So that's actually quite important and feel does add weight to the issue, no pun intended. So that's how we kind of came to our recommendation. Now, this is kind of a sub-study, which I thought was super interesting, because who doesn't like MRI and who doesn't like fat? And that's like the ultimate in having a steak. So then we think about what could you learn from these trials? And so 175 patients underwent both a pre and post MRI, cardiac MRI. And the key thing here is people have been wondering, does this actually reduce different types of fat differently? I am not an obesity expert, but the thing that does matter is pericardial fat. And we think there's many types of pericardial fat. And in fact, these drugs, compared to placebo, did reduce pericardial fat. And that actually may have implications as to how they're actually functioning to improve LV function, or in fact, reducing clinical events. So I think there's a lot more that'll come in the space in the next couple of years, including some work that's being done here. Now, SGLT2s, do you guys want 45 minutes on SGLT2 inhibitors? Probably not. So I just show that there's a lot of trials in this area, a large number of trials in the heart failure space, including HFrEF, HFpEF, and related trials. Now, on the bottom left, you can see all the SGLT2s listed. Well, there's just a smattering. There's like 20, 25 SGLT2s in the planet. On the right-hand side, as you can see, there's selectivity of SGLT2 to 1. The reason I bring this up is the Soloist trial was the first in the area of heart failure to show a substantial benefit on their primary outcome in reducing clinical events for patients with heart failure using sotagliflozin, available in the US and soon to be available in Canada. So that will be something that we'll be adding to the list of things we can use. Now, in clinical practice, I show the slide to show you can pick who you are. You probably know who you are. You can look at your neighbor and you know who they are. But if you're on the left, you're a camel. You're like able to go long distances. You're pretty fast. You're actually okay. You're like, doing rounds with Dr. Ringrose. You had to carry some water with you. It's going to be a long day. I'm kidding, of course, Jen. But that's who you are. You adopt things early and you go far. You could be a kangaroo who's also in the middle of the road. You can kind of see posing. You can actually, when you need to, you can step it up and do the work and adopt things. But most of the time, you wait for others to adopt. Or you can be on the right-hand side. You can be a wombat. Wombat are roadkill. They basically wait for everything to be adopted. They stand on the road. They see the headlights. They get hit. So please don't be a wombat. That's all I ask. Now, I am known to be, and as Dr. Kassan knows, I whine a lot. And yeah, she's laughing, but she knows that's true. I do complain a lot. But as Teddy Roosevelt said, and this I stole from a colleague, complaining about a problem without proposing a solution is just whining. So that is very true. So I have stopped whining. Well, not really, but I have, taken it upon myself and been asked to do things like, change the heart failure landscape. So in Alberta, we've done a lot, and I don't know for people who've kind of trained elsewhere if they've kind of seen in other provinces, but Alberta has been kind of a front runner in the Canadian landscape for trying to change practice. It is not easy, as you can imagine. So we started with the Alberta Cardiac Access Collaborative in 2008. Then we went through the years of the SCN. The latest is the ACA. whatever ACA's adoption of the PIN strategy, we're still trying to feel its way there. But within that, and with my colleague in Calgary, Dr. Jonathan Howlett, we kind of paired together a lot of the work saying, what about implementing pathways in hospital? Kind of get our arms around the hospital scenario. And so that took a lot of people's involvement and engagement across the years. So not trying to shortchange others. There's a lot of people who kind of fed into this. But we developed ultimately this heart failure pathway, which I know many of you just like bypass and just hit to dismiss. You probably should hit accept. And the reason you should is it's not just about physician's care, but actually if you think about nursing, dietary, and other ancillary services, PT, OT, they actually also get the trigger on that pathway if you hit that button. So it's not just about medical care, like can I select that drug, but it does give you some advice as to what drug should I use next? Is this patient on optimal medical therapy? So it does give some suggestions you might find encouraging. And also adding those educational triggers is probably important. We were able to successfully get a QR code for education, like onto the AVS, so that, small wins in life. But it also talks about GDMT adherence, and those patients who are on a pathway, the heart failure pathway, have much higher physician prescription of GDMT. So keep that in mind, as that actually is, we have some data on that, and we'll putting it together in a manuscript to show it's better to be on the pathway than not. Now, we propensity match for all your different characteristics. It still holds out true. So we know the pathway does have some effect. Context matters for any intervention. Dr. Chatur, who is a postdoctoral fellow with us, a cardiologist, she put this really nice slide saying, you can do all the trials in the world, but in the middle is kind of where you kind of want to see the kind of the needle move. You can see different rates of prescription in practice, but on the bottom right-hand side, you see you got to change policy, you have to change patient level stuff, so education, adherence, all those things, and provider level activities. So you have to change all of it. It's a really nice little figure to use because you can kind of see where are the gaps. Now, some of you may have received something in your AHS email, so I'm going to just bare my soul and show you mine version. We started these just a couple of weeks ago. It took a long time to construct. We calculated something called the GDMT score, or MHFC, Modified Heart Failure Collaboratory Score. And that's a constellation of all the drugs that we think have evidence and are endorsed by guidelines, put into a score. And then we released this into the wild by actually going across all providers, across all of Alberta, for in-hospital care. So you all got a report, and you may like it where you land, or you may not. But each of this is very personalized. So it's got your name up there. Then it's got the why, like the background data. Most of you skip through this, I know, which probably you ignore it, get right to your score. That's fine. And then how are you doing? So what's your nearest neighbor, or what's the comparators? And in fact, here's how I scored. Now, remember, I was barely on clinical service between April and June in terms of in-hospital care, but I still had a number of visits. So what it does is looks at patients who are eligible for the drug. It removes those who are ineligible, such as on dialysis. Well, you couldn't have gotten ACE or ARB necessarily. So it already has taken that out of the equation before you say, I only take care of sick patients, blah, blah, blah. That's actually not true. We actually can show that this is actually adjusted for that. But there you are. There's my adherence to each medication. My score was 82%. My average MHFC score, it's pretty good. I was happy with that. I was like a little embarrassed. I was like, I don't even want to open the email. How good am I doing? And you kind of see an assessment of your own scores compared to those in the broader community. Remember, across 100 hospitals and 8 to 10,000 admissions per year, and they're kind of where you are. Even an interventionalist in our group said they were happy to see it, and they said, look, I'm doing great. I was like, you are actually doing good. That's actually impressive. An interventionalist prescribing heart failure drugs. I was pleasantly surprised. So here's the next part, go from your in practice part to how do we make our choices with all of these drugs? And so there's a lot of different pathways that affect the heart muscle, the periphery, and these are the kind of thought process. You got to start with your RAS inhibition, SGLT2s. You can go with all these different, and they all hit a different pathway. And in fact, then all these drugs hitting different pathways is why they also work. Is they're not also just trying to hit the same thing twice. We've tried that with ACE plus ARB. It doesn't really help. And so you kind of want to think about what is complementary to doing that. I'll cover the Victoria trial because it's the latest, largest trial that's just been published at ESC. Quite an important trial, and so we felt that it's quite relevant. Ezekowitz is actually on the ABC form at the very bottom of the form. They added it spontaneously last year in September. Then you can now get it for patients who are recently discharged with meeting their criteria. But this is the Victor trial. There's a follow-on from the Victoria trial, which looked at the in-hospital and very close worsening heart failure population into the outpatient ambulatory care greater than 6 months from a hospitalization. And so it's basically this kind of chronic heart failure population that with HFrEF that you may or may not see in your practice. That's all I do all day long. So kind of what I see every day. So EF less than 40% with a range of NT-proBNPs you can see there. And they had to be beyond 6 months from a hospitalization. That's kind of the core part. And then the typical cardiovascular death, heart failure hospitalization, which is the primary endpoint for almost all of our heart failure trials. 6,000 patients, meaning we're expecting over 1,000 events. Now, here's the part about doing trials. When you first see a Kaplan-Meier, you say, well, that's disappointing because we didn't hit our primary endpoint, cardiovascular death, heart failure hospitalization. So the collective grouping of people involved in this trial, trying to put our heads together, say, well, why is that? And so when you look at this, you can see there's an effect, a hazard ratio of 0.93, but it wasn't the home run we were somewhat expecting. And so we said, well, if it's neutral for its primary, what else can we look at? Can we look at its secondaries? So this trial was the one where we thought ahead and said, well, what we should probably do is power this for the cardiovascular death endpoint alone, because that actually is a key secondary endpoint. And when I say we, it's a collective we. It's not just me sitting around with like a napkin trying to draw stuff up. There's a lot of people involved in these trials to design it. And in fact, here you see that cardiovascular death reduced individually, and you can see heart failure related death, sudden cardiac death, and all-cause mortality, all significant in vericiguat versus placebo. So vericiguat being better than placebo in reducing these bad outcomes. So now you have a bit of a challenge. How do you explain this primary endpoint that was neutral? You've obviously had the drivers being cardiovascular death for the endpoint, and it's quite significant. This is not a trivial amount. But in fact, it looks like in hospital, our typical heart failure hospitalization endpoint, there was no difference. But once you start to include all the other ways people are cared for in the community, outpatient diuretic intensification, initiation of a diuretic, adding a diuretic, those types of things we call ODI or outpatient diuretic intensification, suddenly you start to see the signal. And that's because a lot of the way we practice medicine has changed in the last couple of years. Now we try to keep people out of hospital. We try to keep people like, oh, let's just double their diuretics and use the virtual hospital, or let's do other things other than admit them to Dr. Kassam's CTU service. So that's just a bit of a insight. There'll be a lot of papers coming from that trial to highlight, the places where vericiguat may fit in your practice or not. This is how we mostly make decisions in practice. We think about what's their blood pressure, what's their heart rate, do they have AFib, what do they have congestion that I need to treat as well? And you have lots of choices now. So the key is to not shortchange those choices. But what choices are best? So this is a little bit about where we think it gets super complicated in medicine because you have all these trials. So in 2022, Jasper Tromp, who's this great Dutch and Singaporean researcher, junior ECR, put together this network meta-analysis. And at that time, there is, I think, 80 or some 90,000 patients. This is kind of highlighted. You can see at the very top, RNA, beta blocker, SGLT2, and MRA. That's if you want to reduce things like death, that's what you use. And at the very bottom, you can see the blobogram goes all the way down to placebo, and right above placebo is digoxin. So you kind of see if you're going to go monotherapy, you're welcome to do that, but your patients will not come back for whatever reason. Fast forwarding and including the Victor trial, so we released this at the same time as Victor trial at ESC just about a month ago. We put it all together again. And this is an incredible amount of work to get these things to do. So you got 100,000 patients, 89 HFrEF trials, and it just shows you the very top. If you want to reduce cardiovascular death, that's the choices. And so even if you're doing other things, and you can see even if you're doing a couple of these, you're still getting a cardiovascular death. So 2 is not as good as 3, 3 is not as good as 4. And so 5 is actually the best choice. If you are going to actually want to really continue to reduce cardiovascular death, that is important. So we wanted to kind of drive home that message that polypharmacy, all those questions about that is actually not that relevant for this. If you want to reduce death, this is kind of what you have to do. So this is Caribou. For people who don't know, just in case there was somebody, Caribou have no RCTs. They are not indicated for heart failure. So whatever other thing you're choosing to start in a patient with heart failure are just like Caribou. Okay, sorry. It's a nice picture of Caribou. So what's coming next? And I think we have to start to think about, that's nice and all, but what are our patients who are admitted to hospital and we have they seem to not respond to our therapies or whatever that might be. I will not talk about diuretics at all. Diuretics are challenging. Probably what you want to hear the most about, but we have the least amount of new information. So these are the types of trials that are ongoing. These are the kind of molecules where they'll have some big impact. So we talked about soluble guanylate cyclase stimulators, Versigua, we just talked about. Cardiac myosin stimulators, I'll come back to in a few minutes. PDE9 inhibitors, you know there's a 3, you know there's a 5, now there's a 9. And it turns out 9 is actually quite important for molecular mechanisms for a lot of reasons. Aldosterone synthase inhibitors, these are kind of the next MRAs, the way to think about them. They work differently, but I just make that linkage. That's kind of the way we think about them. And there's a lot of cadrostats. They all have a cadrostat. Can't even remember the other cadrostats, but they all have the kind of same last part of their name. Ziltivekimab, a very large inflammation targeting IL-6 molecule that is being tested in HFpEF. And then gene vectors. So there's a gene vector trial, which is super cool, which is protein phosphatase, protein inhibitor 1, PI1. And it's actually, it should be fully enrolled by the end of this year. And that's actually super interesting because it means you might be able to change the pathophysiology of the disease itself. And then the relaxin peptides, and for people with secondary PH, associated with heart failure is actually super an interesting area. Lots of trials in devices. So things like left bundle pacing, you might see that now in the reports that they didn't do CRT. Well, they did do CRT, but there's no left lead. Oh, there is a left lead. And like there's things like left bundle area pacing. So that entire area of how people pace in patients with heart failure has changed a lot. So you might see a lot more of that. Very large RCT going on called left versus left. Great name for a trial because they're both targeting different ways of putting a left-sided lead in for CRT in our RCT. So we generally think this will be a positive trial because LBBA, left bundle branch area pacing, is usually better tolerated and maybe better for our patients overall. Contemp ICD, we're going back to the ICD well and saying, do people need an ICD? So for this is it for people with an EF less than 35%, randomized to ICD or no ICD. And that's actually kind of going back to the SCUT days, which is a trial that kind of really established whether or not we should use an ICD and challenging that, saying we have great GDMT now. Should we use it, do an ICD? A shameless, and totally shameless plug for the types of trials we're enrolling from. Now, I wear several hats. At CVC, we kind of design and direct and publish, analyze trials. So we do all the operations, we do everything. So this is just the heart failure subset of things we're involved with. Of course, there's lots of other stuff in different areas, including acute coronary syndrome with all my colleagues. So that's just this is a snapshot. And then I wear the hat of being the site PI of doing all these trials. So I get to suffer through all the challenges of enrolling patients. And also the great part when a trial, can actually hit its mark and then show that the effect we were looking for and then change a guideline because we enroll patients. So I kind of look at it as part of our kind of contract here to make sure we do that. So on the left to right, redefine, confirmation, and finality are trials with finerenone, looking at different substrates of that. The heart platform, I'll show you in a minute. Contemp ICD, I just mentioned that. It's a partnership with the University of Rochester, CDC, and it's a PCORI grant. And so we'll see if we can enroll enough patients to get to the next gate, which means that we can do the large part of the trial. Converge, I'll mention again, and Comet, I'll come back to in a moment. But this is all things you might be approached for. I might actually call you up and say, or a secure chat, you can say, hey, this patient looks like they might be eligible, or this patient's interested, just so you know. And that's kind of where we're at. So in the last few minutes, I will talk a little bit about things that also targets the pathophysiology of a disease. So this is a drug called omecamtiv. Now you could have come up with a better name. So you added mecarbil. So it's omecamtiv mecarbil. And that is not going to roll off the tongue easily for many people if it goes into practice. The way to think about this drug is it's a specifically targeted inotrope. So we think about it as an inotrope, and it just makes the myosin basically stimulation. So you basically have more myosin activation when the myosin is being activated in the heart muscle. So that's good. More myosin is good. Now, if you have hypertrophic cardiomyopathy, all those drugs that are targeted specifically for HCM do the exact opposite. They basically relax it. So the exact same cardiac myosin, if you stimulate it one way, it's for HFrEF. If you relax it in a different way, it's for hypertrophic cardiomyopathy. So it's actually all came from the same number of investigators, and they split off the companies and the molecules. So just keep in mind that's the same way that they work. One pull, one not pull. The key thing here is unlike things like dobutamine or milrinone, which all increase the inside the cell intracellular calcium, so they actually disrupt calcium handling badly, which they increase arrhythmias. These ones do not. In fact, they tend to decrease arrhythmias for a lot of different reasons. They also increase stroke volume directly. So you give a dose, the stroke volume of the heart goes up and cardiac output goes up. And as you kind of up the dose, it's very dose titrated. Then you do an 8,000 or 8,200 patient trial and show that it didn't change clinical outcomes as you expect. So there's a 20-year development cycle of this drug, giant trial, and didn't hit its primary endpoint. It clearly did do something. It hit its primary endpoint in the way that we think it statistically did, but from a regulatory approval and marketing a drug, it didn't do enough. And so the drug was felt to be not effective in reducing cardiovascular death. Even though it targeted the main pathophysiology of HFrEF, increasing contractility. So that's a bit frustrating. You can imagine you've spent 20 years of your life developing that and done this mega investment in a trial and patient exposure. We enrolled a lot of patients here in both the cosmic, atomic, and then galactic trials. And so we actually were deeply involved in getting patients involved in this. And so we, it's a bit eye-opening that not everything works as it should. So then along comes a secondary analysis. And what you realize is that when you look at 8,000 or 8,200 patients, you can look and you can do all the subgroups if you want, but they have to have a good rationale. This one was looking at just those patients with a much lower ejection fraction. So you have less than 28% versus that was the median in the trial, looking below. And you can look at it all different ways. And on the right-hand side, you can see the treatment effect of the drug was highly effective as the lower the ejection fraction went. So that fits with the understanding of the drug. That's good. But you've got a kind of a neutral trial result, a primary for positive and neutral in the eyes of the FDA and others. So what do you do next? And so this is where you have to think about, what do you do next? Do you just abandon ship and say this drug's dead? No, you do want to do another trial. And this is where we're currently enrolling into the COMET trial. And it's got a very selective group of patients, an EF less than 30%, recently or admitted or recently admitted with heart failure to the hospital in the last 6 months with an elevated NT-proBNP. You can see those levels. So this emulates that group in the very large trial that actually had a benefit. So it's gone through 1,000 trial emulations to figure out, could this work? Did this work? Is it a spurious finding? But when you actually kind of do that and it's robust, this will probably, if it works as anticipated, this trial gets enrolled, it will probably be positive based on that. Now, that's why we do the randomized trial, to figure out if it does work, because many things can happen that are unanticipated. So we are enrolling as a site doing this, and we're also running the Canadian contingent of that with the CDC, our CDC team, and of course are deeply tied to this project. The Converge project is a heart and stroke funded project, which came out of the Brain Heart Alliance, one of these mega heart and stroke initiatives that we've kind of shared with the Ottawa Heart Institute. So this is a trial using vericiguat versus what we started as placebo, that got complex, so vericiguat versus control, and testing in patients with heart failure, any HFrEF with non-reduced EF, if you want, however you want to call it, and looking at what happens if they have very mild cognitive impairment. Turns out, this will be of no surprise, patients with heart failure, about half of them have mild cognitive impairment by any scale. It doesn't matter if you do MoCA, MMSE, SLUMS, if you do the European Psychiatric Consortium guidance, and this was published by Dr. Khanna. They're looking at this in our patients here, recruited here. The patients have a large degree of mild cognitive impairment. So this trial is testing, well, what if we use a drug that may affect the endothelium in the brain, if that makes a difference? We have no idea if this will work, but we're sure going to get a lot of information to see if that alters the function, even in patients with mild cognitive impairment, not severe dementia or other areas that I would have zero clue about. And we're using brain MRI and cardiac MRI to look at that, because we figure we want a small sample of patients, see if this is worth kind of pursuing. The heart platform trial, which is, I'd say, I spent a lot of my time in the last little while. We've been designing and developing this. So like many platform trials, REMAP-CAP, recovery, you've seen all these ones floated around. They're quite important. They have a master protocol, and they have domains which are testing, drug X versus Y, strategy Y versus Z. And that's really important, because you can actually then efficiently incorporate people into a protocol and then a domain and subsequent domain. So hopefully it should make it a little easier to recruit patients and get endpoints that matter done quickly. So you want to be a bit more efficient, and you want to have it also have really good ideas that maybe not the focus of our industry colleagues, but could be, but also strategy things. So this is where we are, and it's kind of, we shamelessly stole our name from a previous effort, the Heart, Alberta Heart. We just kind of changed a few words in there so we can keep the word heart in there. The first thing you do is come up with a good logo, funded by University Hospital Foundation for this pilot work. And so we're getting a long way. So here's kind of pictorially how it represents a master protocol, each of the domains. We have the first domain that's going to Health Canada, or it's on its way to Health Canada very soon, is ready at the RABs to be looked at. So we're quite a long ways away. It takes a lot of effort to put the overall platform together, but once it's rolling, it should be easier to add in key ideas if people want to test A versus B. And we're very happy to have collaborators or people who think they have a good idea. There are two states, the worsening heart failure, which is hospital-like, and recent worsening, and ambulatory, which is kind of the outpatient world in broadly speaking. So this is kind of what they would look like. So things like virtual hospital is kind of the worsening heart failure group. And those are the trials like you've heard about the Impulse trial or others. That's kind of what their population we're looking at. And the ambulatory care, which is our typical outpatient HFrEF population that we'd see in our outpatient practice. So I try to keep us on time and make sure we have enough time for questions. This is the way I think about it. We've evolved over time. It's time to really update our clinical practice. I think there are therapies out there. I didn't talk about a whole whack of different strategy trials and other interventions that occur in hospital or other things we've tried or that don't work, but I'm happy to take those questions about that. But the heart failure research community is very strong, and it's particularly strong here at the U of A with all of our collaborators who are kind of doing kind of cool things. And so just a quick note of thanks to this entire ecosystem of people and of all organizations, et cetera, that kind of allow this work to proceed. So thank you very much for your time and happy to take some questions.
Thanks, Justin. I mean, that was so many aspects, not just a sort of master class in clinical trials and all the evidence, but also the implementation part of it, right? The implementation science part of it. I just wonder, because it is so relevant for a lot of the clinicians in the zone, corridor, whatever we're called now, you know, the CPSA has a requirement now for being involved in some kind of quality improvement project. And I wondered if that GDMT trial, GDMT score, since I don't know that there's anyone within our department that doesn't look after heart failure patients, really. I mean, I think even the dermatologists probably have to come across that.
Everybody does.
Right? So is that a potential avenue for, you know, at least a little bit of the reporting requirement and things? And do you have any further suggestions for how to use that?
Yeah, so that's a great idea. I think the heart failure space has got so many things to improve. Like there's no the Q and the I will batch together. So that what we worked with ACE with originally SCN and now ACA, that's a great area if you have ideas to think about approaching. There's lots of like mini QI things that you could just generally build into that. And I think that's an area that's ripe for just how do you change practice and how much of your own sweat are you willing to do? Because I think some of these take, anybody who's done QI and deals with clinicians, I don't know how you do it, Norman, which we're terrible people to deal with sometimes in QI, but in the world of QI, it's actually a really hard job. So if you have good ideas, that's an area that's ripe for the picking.
You guys are keeping all of us that deal with heart failure on our toes. So thank you for that. It's whether it's the naming or the drugs or the biomarkers or whatever, it's definitely keeping us on our toes. Saiful has a question and then we'll go from there.
No, just a comment on the same thing. It would meet the requirement of PPID. There are 15 domains with CPSA outline, and it's tracking your data. And can easily be expected from Connect here to utilization of heart failure background care pathway, and can be extrapolated over 6 months. Sit down now after 6 months, pick up your data, how much you see, and then right back to do the trial as part of the template the data is provided. So that all the
That's great. I didn't know about that. That's amazing. So that sounds like something I should learn about my own personal QI.
Jeff.
Thank you for the great talk. Thinking about all these additive medications, right? I'm wondering if we'll get to a point, like especially with like finerenone MRAs and the ACEs NARBs, and then these new aldosterone synthase inhibitors. Do you think we'll ever get to a point where we can maybe use the aldosterone synthase inhibitor instead of the ACE and ARB, or like start decreasing things? Because Like, there's a lot of meds at the top of that,
Yeah, it's a great question about, at some point, polypharmacy becomes quite grand, and maybe these are overlapping pathways. They're not additive. I think that's exactly why we kind of have to develop the drugs in the first place to get them there. And then people go along and they do things like the TREAD trial, TREAD-HF, for those who just don't. It was actually a de-escalation trial to take away drugs and see what happened. Turns out it was bad for most of the participants. They did an extension study. It was consistently bad. So taking away was not good. But it's still unclear as to if that was, a TREAD-HF2 or a 3 or 4 would really be the same, because we have different therapies now. So it's making more phenotypic-based choices might be a good way to strategize. I mean, in the world of like ACS and other areas, they've gone ahead and done that. Like, how long should aspirin be there or not? Should we use that for 3 months or 12 months? Those things have percolated through. I think we're almost there. I think we've got almost there to start removing things. We certainly know what doesn't work, which is some beta blockers don't work. So don't use the non-evidence-based beta blockers. Don't use ACE plus ARB. Like, these things we know because people did trials, but I think we're going to get there. Whether or not we get there quickly is hard to know. That's where I think academically led trials can really help say, ask those questions, pilot that work, and then take it forward. It's got to have a really good rationale and a very clear patient group that's in the way you follow it. So these are not easy trials necessarily to do, but they're the core as to how we practice. Can I get rid of this drug tomorrow?
Even the much maligned digoxin takeaway, right?
Yeah.
I mean, would you agree with that, or would you say that we've gotten past that?
I agree that it's maligned, but I also agree we should take it away. So both
Okay.
those are true. So there's a lot of reasons why I think to think that digoxin it has probably no additional benefit. That's why our guidelines have kind of taken that approach, and our guidelines are pretty consistent. Now, removing it from practice is reasonable. Now, everybody's read the DIGIT-HF trial, which is using digitoxin. It's a kind of I'd say, challenging trial to interpret for many reasons. So I don't think it has any real applicability for our own practice. However, there is a very large trial coming out next year that'll be, I think it's called the DECIDE trial, which will actually be about digoxin in heart failure. And it's a large trial, well done. We will understand if there's actually any added benefit in the modern era. So I think we're thinking about the reverse. If digoxin was released today, it would never get approved. Not a drop of it. And so that's the other way to think about it. So it is.
We do still see patients on it.
Yeah.
Though.
Yeah. And sometimes we should still think about removing it if we feel it's no longer has its value. We should think about that.
Okay. There's a few online that I'm gonna quickly jump to after Dr. Demet.
Oh, thank you. Justin, I can't believe you had the week prepare for that. I work in sarcoidosis, and so 2 quick questions. There's a lot of new therapies you've talked about. What is the administrative burden going to be like for us that are trying to adopt this? And I work with complex sarcoid patients, and would these guidelines apply to people with sarcoid reduced?
Reduced ejection fraction.
There we go.
FRAC.
Okay.
Yeah.
I'm struggling with that.
Yeah.
But, due to a specific disease like SNR.
Yeah, so let's start with the administrative burden. Alberta Blue Cross has thankfully put them all on one page for the drugs, and they've covered it on the same form, thankfully. It's not on the same e-form, but on the same form, paper one. So the administrative burden should be lower, but it's still there to fill out an RNE form for Ezekowitz, or even our good old-fashioned drugs are still there sometimes. So there's some, but these are now in the community. And in fact, most provinces have moved them off a form-based thing. So the administrative burden is being removed. The sarcoid area, there's like a large RCT being run out of Ottawa called CHASM RCT, which is ongoing. But I think, do these guidelines apply? I'd say broadly, yes, but I'd be much more selective of which drugs I would select to use. I think they will have the effect because the myocardium is impacted, and they're not. These trials do not exclude always sarcoid or known sarcoid or known amyloid, but they may exclude very high ATTR amyloid end of life. Our patients never make it into these trials. How I would practice, I would probably apply the guidelines broadly, but I think, does this drug kind of match with all their other risk factors of deterioration of the renal function or something else? So I think it's a great area for also thinking about how many people with sarcoid are enrolled into these trials. And I don't think I know the answer to that question.
I'm going to ask you something that's online here that's related, and that is you didn't very much touch on it, but I wondered if, more, yeah. So there's a question about cost effectiveness. I mean, we all know death is cheaper than, all that, and that taken into account. Well, do you have any, sort of evidence or even opinions on the cost effectiveness piece
I
of
have
all
lots,
these meds?
I have lots of opinions, like a lower level of evidence. So every hospitalization costs about $14,000 of heart failure. That's an Alberta data, Alberta piece of data. Mean length of stay is about 8 days in Alberta. So the cost effectiveness of reducing one heart failure hospitalization is usually for a drug that does that is very cost effective. That's why when you start to look at trials that don't reduce hospitalization, it's very hard to prove cost effectiveness unless you attribute some cost to the cardiovascular death or all-cause mortality. Most of these drugs over the lifespan are cost effective. If you look at the 50K or 60K bracket. It's not my area of expertise, but in general, now all the heart failure drugs are going in the world being generic, so it becomes a lot easier from a drug cost. But reductions in hospitalization drive all the cost effectiveness analyses in the heart failure space. Broadly, they're probably cost effective. Even CRT, which is a device, so you can think of a very expensive therapy in theory, it's cost effective because it does reduce hospitalizations quite substantially. Now, that's over the 8 to 10 year lifespan of a patient, but it may actually diminish over diminishing rewards or not. It's hard for me to answer it better though.
Some really good questions here. I'll just start with one around nitroglycerin, which apparently is also a guanylate cyclase stimulator. And has there been any further work with nitroglycerin in heart failure?
Yeah, so there's been a lot of trials done before I was born that showed it had benefit when we had nothing else. And then there's a couple of trials in HFpEF showed no benefit, probably some harm. And generally they work a little bit differently, like they're giving like a spray of nitro or even Iserdil or Imgur, one of these other nitric oxide deliverers, is like carpet bombing and it's just broad. It's not hitting the SGC system the same way, so that they are very selective. And in fact, that was one of the first thoughts was, why don't we just give more nitro and see if that works? Turns out people have tried that and in smaller trials, even more recently, it doesn't have the effect we think it should. And it's probably because it's not an effect, it's a very effective delivery by spray, but it's not effective to getting to the targeted area. And that's the SGC molecule, which is what you really want to change. So it's a good question to think about. Those earlier trials were one of the few things that kind of started to work in the 1970s and 80s, but that was all people had. So.
You're that young, huh? There's a question around outpatients who have familial dilated cardiomyopathy, but never had clinical syndrome of heart failure. Would you push GDMT in those patients, or what are your thoughts?
Oh yeah, that's a great question. So first of all, we have a great cardiogenetics clinic that sees patients like this, and they've been diagnosed. They get their genes SNPs all looked at. So this is a population we have to think about. My practice would be when I see these individuals, it's very much a shared decision making if they're willing to take a medication. If they have an EF of 30% and they have this giant globular heart, but they're asymptomatic and playing soccer, it's tough, right? I tend to just have a good discussion about, if I had to do a couple of drugs, which ones would those be? And often I will start therapy, but I will do it with an active disclosure that we don't have a good data set from which to base that. But I do fundamentally think it's probably helping the myocardium, which is probably a good thing. But it's reasonable. So there's not a solid set of data to say doing that is helpful. In the pediatric world, they've struggled to get these trials done because it's actually hard to do trials in pediatrics. And so they've actually struggled to even show that even in that scenario, which you think would be much higher risk from a long term, that we don't have that data set to kind of rely on. So I tend to start the therapies. I tend to have a good discussion about what side effects and risk benefit ratio, and how long they're going to be on them. Often they're like 35 years old, so that's going to be a bit of an unknown for them. That's where the gene vector trials, I think, will have a big role, where we'll say, to get GDMT, let's go gene vector way. And I think that's what I would actually probably be advocating for.
Okay, a couple more questions online if there's nothing here. One is around coronary revascularization in patients without ischemic symptoms. Has there been any is there any role for it in patients with symptomatic heart failure?
Yes, so every one of our heart failure conferences has a debate on this exact topic because it's such a great topic. First of all, we are terrible at assessing symptoms that are attributable to coronary disease. So I would say from that basis, it's almost irrelevant to say, oh, did they have chest pain or not chest pain? It's if they have symptomatic, you don't quite know if their symptoms are from the coronary disease, myocardium, or something else. So I'd like skip the symptom assessment per se. If they're short of breath, that's good enough for me. That's next. The next question is if you revascularize individuals that have a, let's say non-ischemic cause, they have one lesion that maybe is an RCA, like probably marginal data to support that. If they have multivessel ischemic cause for their cardiomyopathy, it's probably good. There's better data to support that. In the middle is you have people who have a mixed cardiomyopathy. They have like a lot of hypertension, maybe it's burnt out hypertension. They got a couple lesions. You're like, should we do this or not? We tend to favor revascularizing in that case. And most of it's due to uncertainty. But there are trials that have been done, some Canadian trials, which show there's probably some small benefit. It is not sizable though. It's not a dramatic yes or no question. It's more of a nuanced question.
One last question, if you want to bring it up, just because it's a little complex. Sorry.
No problem. Okay. Yeah, so a great question about Ivabradine, and what's being asked is, I'll just read out. The question is asking, would you use Ivabradine in patients with a heart rate above 70 or 77, but with a lot of yeah, I know, that's okay. That's okay. Here it is. If people have a lot of frequent PVCs and a decreased LV, would we still use Ivabradine because the heart rate is maybe not 70 per se in the way those PVCs are counting in there? I probably would think twice about it, only because it's not how the trials have tested to show that it actually has an effect. Now, do you run a small N-of-1 experiment with that patient to try it for a while at 5 VID and see what happens? Sure, and then do a Holter and see what happens. I just think those PVCs aren't really counting in the way we think about counting to 70 or 77 beats per minute from an outcomes perspective. So I think that's probably not exactly the crew I'd go after for that drug. And probably make some different choices about what we'd go after. It's not an unreasonable N-of-1 experiment though to try with those kind of guardrails and then repeat the Holter or longer ECG just so you kind of know if that's making a difference. You might just make them really bradycardic and still have PVCs, and that's the worry.
All right. So I mean, a few take homes. Make sure you click the GDMT button when you admit those patients with heart failure. And as soon as you put it in as a diagnosis, I think it pops up, if I'm not mistaken. You need to develop now some smart text so that we use the right terminology, HFmef, HFnref, whatever it is. And of course, if you do have patients, our investigators are actively enrolling in these amazing trials that you're doing. So with that, Justin, thank you so much for putting this amazing talk together. I know we all benefited from it, and I think we need to have them back like very, very frequently. So just keep that in. Thank you.